Welcome to AETCM, the emergency medicine channel. Today, let us discuss about one important neurological disorder, that is Parkinsonism. Parkinsonism patients can come to emergency room. Most important probable diagnosis in them will be aspiration and aspiration pneumonia. They can also have urinary tract infection, hyponatremia, history of falls. All these things are very common. Fall is a very important problem in Parkinson disease. Parkinson as such can produce forward fall, and Parkinson plus syndrome can present with backward fall. So many abnormalities patient can come to OPD or emergency room with Parkinsonism. It's a disease of elderly individual. So we have to be very careful because they can also have associated other features, autonomic dysfunction, coronary artery disease, so many other things also can be there. Now, if we see the classification of movement disorders, or sometimes we call it as dyskinesia, akinetic rigid syndrome. Dyskinesia means movement disorder as such. Akinetic rigid syndrome means rigidity is there, movements are completely reduced. We are going to discuss about akinetic rigid syndrome, in that Parkinsonism. So in Parkinsonism, again you have primary Parkinsonism, that is Parkinson disease, idiopathic Parkinsonism, secondary Parkinsonism, that is due to something secondary like tumor or hypoxemia, whatever it is. Parkinson plus syndrome. Parkinson plus syndrome is Parkinsonism is a primary problem which originates from the substantia nigra. So it's a problem in the substantia nigra. That may not be associated with other finding, like a patient may not have pyramidal tract lesion, patient may not have autonomic dysfunction. But Parkinson plus syndrome means one more part in the neuronal system will be involved. So that is Parkinson plus syndrome. Now, Parkinson disease or primary Parkinsonism or paralysis agitans, there will be depletion of pigmented dopaminergic neurons in the substantia nigra. You can see here substantia nigra. So substantia nigra, this given as black in color. So substantia nigra, you get dopaminergic neurons. They actually help us to move or do things with our hands, legs. So normal movements will be controlled by this area. When the dopaminergic neurons are reduced due to some immune mediated destruction, Parkinsonism will develop. If Parkinsonism is only confined to that area, the pathology is only confined to that area, that degeneration is occurring only that area, you call it as primary Parkinsonism. In that, there are three important features: tremors, bradykinesia, rigidity. Tremor means especially in the hands. Then bradykinesia means movements are completely reduced. Rigidity is patient will have like when we are examining the tone will be increased. A type of hypertonia is rigidity. Another important problem is a postural instability. Most of the time, Parkinson patient will have a forward droop. So this is the legs, and patient will be, this is the head. So patient will have a forward droop. Okay. So that postural instability is very important. Patient can fall forward. Whereas Parkinson plus syndrome will have rigidity in the spinal muscles, and they can have a backward bend and they can fall backward. That is Parkinson plus syndrome. Some of the Parkinson syndrome, not in all. And sometimes postural hypotension can be that. BP can be low when they are standing up. Okay, so hypotension can produce postural drop and they can fall. Postural hypotension is a feature of Parkinson plus syndrome, but some drugs used in Parkinsonism also can produce postural hypotension. Now, there are various causes for secondary Parkinsonism. It can be due to drugs like methyl dopa we use in hypertension. Reserpine is also used in hypertension. Carbon monoxide poisoning, chronic carbon monoxide poisoning, magnesium, methylphenyl tetrahydropyridine toxicity, Japanese encephalitis, or any other encephalitis can produce secondary Parkinsonism. Syphilis, repeated head injury, so especially boxers. Wilson disease, another important degenerative disorder which involves brain and liver. Eyes also will be involved. Many patients who is having chronic vascular disorder, like patient who is having hypertension, diabetes, vascular pathology, they can also sometimes produce Parkinson-like features. So vascular disorder can be due to various disorders. That all disorders will produce vascular changes, and some patients who is having vascular problem like atherosclerosis, they can progress to Parkinsonism. These patients will never, most of these conditions will not respond to carbidopa, levodopa. That is a drug of choice in Parkinsonism. They will not respond. Again, some drugs can produce Parkinsonism and atypical Parkinsonism. Atypical Parkinsonism also we'll see afterwards. But the main feature of all these secondary Parkinsonism, they don't respond to carbidopa, levodopa. Parkinson plus syndrome or multi-system atrophy. Previously it was called as multi-system atrophy. Nowadays we call it as Parkinson plus syndrome. That means along with substantia nigra problem, you can have other areas are also involved. So like cerebellum is involved, motor system is involved, eyes are involved. Some conditions called as Shy-Drager syndrome. In that, dysautonomia, autonomic dysfunction will be there associated with Parkinson. So they have increased sweating, palpitation, tachycardia, bradycardia, fixed heart rate, postural hypotension. All these things are very common. So any patient who is having postural hypotension in Parkinsonism, early itself you have to suspect Shy-Drager syndrome. Progressive supranuclear palsy, Parkinsonism with gaze palsy, especially vertical eye movements will be reduced. So patient will not be able to look up or down, especially looking down. They have difficulty in climbing down the stairs. Pyramidal tract lesions, so patient can have rigidity. Along with the rigidity, patient can have increased reflexes. Normally Parkinson patients will have normal deep tendon reflexes. Here reflexes are increased. Cognitive impairment, most of the Parkinsonism patients will have normal memory, but here patient can have diminished memory. So Parkinson with dementia. Olivopontocerebellar atrophy, again Parkinson plus cerebellar findings. Now, if you see the features of general like Parkinsonism, general examination, most of the patients are depressed. Maybe they are not able to move or do things properly. They are depressed and they may be anxious about their disease condition. Some patients will have cognitive impairment. Mostly Parkinson plus will have cognitive impairment. Sleep disturbances can be there. Mask-like face. They will be unable to smile or express their feelings. So mask-like face. Siluria. So drooling of saliva from one side. It is very, very important. Staring look, that is because of infrequent eye blinking. Their eye blinking will be infrequent, so they look like a it look like a staring look. And greasy skin will be shining. Monotonous speech, so normally when we talk there will be ups and downs in talk. Okay, it will be like this, but these patients will have a low volume, but it will be monotonous. There will not be any expression in the speech. Soft speech, that is hypophonia. Universal flexion, you can see here patient is universally flexed, limbs will be flexed, hip will be flexed, head will be flexed. Okay, so patient will be universally flexed and they may fall forward. So that is very important. You can see here patient is universally flexed, here it is flexed, here it is flexed, here it is flexed, even hands are flexed, knee is flexed, so everywhere flexed. So uniform flexion is a classical finding in patients with Parkinsonism. They have forward tilt and they may have a forward fall also, but whereas Parkinson plus syndrome, back rigidity is classical, so they can have a backward tilt and backward fall. Now, if you examine the rigid hands or upper limb, both upper limb and lower limb, upper limb you have cogwheel rigidity. It is like a cogwheel. Here you can see it is the rigidity is the tone is hypertonia and it is broken. So cogwheel type of rigidity in upper limb, lead pipe rigidity in the lower limb. So cogwheel means there will be break in the tone. A lead pipe means continuously they have increased tone. So the main difference between spasticity and rigidity, spasticity only one group of muscles are involved, whereas in rigidity both agonist and antagonist. So both movement up, both if you are seeing the upper limb, both flexion and extension will have increased rigidity, whereas in spasticity only flexor tone will be increased, so you will have difficulty in extension. Now we have already seen that rigidity and spasticity there is a difference. It's a sign of rigidity is a sign of extra pyramidal lesion, whereas this is a sign of pyramidal lesion. Then it is class 5 type of rigidity in lead pipe in lower limb and cogwheel in upper limb. And it is velocity dependent. This is velocity, spasticity is velocity dependent. If you increase the speed, the spasticity will increase. Plantar may be extensor, so this is a sign of pyramidal tract lesion. DTRs are all exaggerated in spasticity, whereas DTRs may be normal. Deep tendon reflex are normal, but in Parkinson plus syndrome, we can see DTRs may be exaggerated. Now, if you see the posture of a Parkinson patient, you can always, it will be very striking that patient is stooping forward. So, patient is stooping forward in Parkinson's, and they can have frequent falls towards anteriorly or front, fall towards front. Short shuffling steps, that is very important, short shuffling steps. So if you are seeing a normal person, they take longer steps, but here it is very short steps. Now if you ask the patient to walk, you can see that they will have difficulty in starting. Slowly they will start, then the speed may increase. Then short stride, rapid steps. Initially it will be slow, then it will be very rapid, but it is short steps. Arm swing is reduced. Impaired balance. Suddenly if you ask the patient to turn, they will have difficulty in turning. Slowly they will turn to one side. Okay, so that is very important. Freezing of gait, that is very important. So when you ask the patient to walk, sometimes suddenly they have complete freezing, they may not be able to move forward. Postural instability, most of these patients will have fall forward. Now tremors are very important. You can see this is a pill rolling movement. So adduction and abduction of thumb and other movements of the fingers. You can see this finger is opposing this, thumb is opposing our next finger, and that movement is like a pill rolling movement. So that is very important. Pill rolling tremor is a classical tremor seen in Parkinson disease. Adduction and abduction thumb, flexion and extension of fingers, supination and pronation of forearm. So that is a classical tremor you see in Parkinson disease, but this may not be seen in secondary Parkinsonism or atherosclerotic Parkinsonism. Tremors are mainly seen in arms. It can also be seen in feet. Tremors are mostly unilateral in Parkinson disease, but bilaterally in other types of Parkinsonism. It may appear in lips, tongue, jaw, but spares head and neck. So head nodding will not be there in Parkinsonism. The tremor is early in Parkinson disease, and most often it is intermittent. Sometimes you can see it, sometimes it will disappear. It disappears during sleep. So these are the typical features of tremors in Parkinson's. So it's a resting tremor, not an intentional tremor. Now there are a lot of eye signs. In that, one important sign is Meyersson sign. Meyersson sign is your glabellar tap. You are continuously tapping on the forehead. So throughout the tap, after sometimes normal person will stop blinking, but this Parkinson patient will have difficulty in stopping, so they continuously blink. Decreased blink rate, hypometric saccade, that is decreased velocity of fast movement. If you ask the patient to do it fast, look very fast, so normally we look towards object very fast, but this Parkinson patient's eyes will be very slow. So even if you move your finger very fast, the eye movement will be slow. Broken pursuits, that is slow movements will be broken. So if you ask the patient to follow a slow object, normally it is a very smooth follow up, but during that following, if you see the eyes, you can see that the eyes will be broken. So fast movements are made very slow and slow movements are broken. So that is the main finding in Parkinson patient. Now, if you ask the patient to write something, they'll have micrography, small letters. So that is very important because they will not be able to write, sign the check and all. So it will be like, it will become invalid sometimes. So we have to be very careful. Orthostatic hypotension, constipation, urinary urgency, excessive sweating, bradykinesia, handwriting micrography, these are the common finding. And in that, orthostatic hypotension is very important because many patients who is having Parkinson disease, normally they will not have this problem, but Parkinson plus syndrome, this is a classical finding. But on Parkinson disease, when you are giving carbidopa and other drugs, that itself can sometimes produce postural hypotension. Now, other features of Parkinsonism with Parkinson disease. So we have already discussed that poor response to levodopa is a classical finding in Parkinson plus syndrome, and falls at presentation is early in the case of Parkinson plus syndrome. It's late in the feature of Parkinson disease. Forward fall is a feature of Parkinson disease. Backward fall is a feature of Parkinson plus syndrome. Symmetrical onset is classically seen in Parkinson plus syndrome, but unilateral onset then spread to both sides is a feature of Parkinson disease. Rapid progression is a feature of Parkinson plus syndrome. Younger age is a feature of Parkinson plus syndrome. Lack of tremor is a feature of Parkinson plus syndrome. Dysautonomia occurring early is a feature of Parkinson plus syndrome. So these are the features which can tell you that this is Parkinson plus syndrome, not Parkinson disease. Now, Parkinson plus syndrome, we have already seen that the most important feature will be associated finding. Patient can have other than whatever we discussed in Parkinson disease, like increased tendon reflexes, extensor plantar, spasticity, like that pyramidal tract or cerebellar signs, or other features like ophthalmoplegia, dysautonomia, not responding to your treatment. All these things are features of Parkinson plus syndrome. Now, normally we don't do any investigation for Parkinson disease, but if you want to rule out other conditions like syphilis, you have to do VDRL. Wilson disease, you have to go for liver function test, ceruloplasmin, copper. MRI brain should be ruled out. Structural disease like some brain disorders can present with Parkinson, hydrocephalus, tumors, lacunar infarcts. PET scan is FDG PET scan can be done in patients who is having Parkinsonism, and rule out other causes for Parkinson plus syndrome. Now, management, normally when the patient come to emergency room, we have to always take care. Most of these patients come with aspiration. The most common cause of death in Parkinsonism is aspiration and aspiration induced problem. So aspiration should be taken care. Airway, breathing, circulation should be taken care. They can have postural hypotension, so that has to be taken care. Then routine treatment. Anticholinergics can be started for many patients, they have severe rigidity and bradykinesia. Benzexol, orphanedrine, trihexyphenidyl, all these things can produce reduction in the rigidity and bradykinesia. But the most important drug will be levodopa, carbidopa. So it's a dopamine precursor. It improves all major features of Parkinsonism, including bradykinesia and if levodopa is administered orally, 90% of the drug is decarboxylate to dopamine before reaching the brain. This can be prevented by adding a decarboxylase inhibitor, that is carbidopa. So normally we give levodopa carbidopa combination, that is 2500 combination, 0.5 milligram, 0.5, or that means half of the tablet will start initially, because this tablet has got some side effects like hallucination, delusion. So immediately after starting, some patients can have agitation, shouting, anxiety, fear, all these things. So you have to start very low dose and slowly increase the dose. So start very low dose and slowly increase the dose. That is the most important thing. On and off phenomena, after some times patient may not respond to your treatment, and during that period patient slowly develop signs of resistance. So patient can have sometimes completely off. Dopamine receptor agonists like bromocriptine, cabergoline, ropinirole, pramipexole, all these things can also be tried. So, ropinirole, we have given the treatment dose here. Okay. Then, catechol or methyl transferase, entacapone, 200 milligram, levodopa, with levodopa you can give. MAO inhibitors, selegiline, risagiline, safinamide, all these things are used, they are adjuvant therapy with response fluctuation to levodopa, initial monotherapy in young patients. These drugs can be added to basic regime, that levodopa carbidopa regime. Treatment of non-motor syndrome like erectile dysfunction, we give sildenafil, polyethylene glycol for constipation. Constipation is a major problem in Parkinson disease or Parkinson plus syndrome. Modafinil, that is excessive daytime somnolence or sleep. For insomnia, you can give melatonin. Levodopa carbidopa should be considered to treat periodic limb movements of sleep in Parkinson disease or restless leg syndrome. There is a different disease. Restless leg syndrome is not part of Parkinson disease. Methylphenidate for fatigue. Deep brain stimulation is a newer modality of treatment, like we use pacemaker. Here also we use a type of pacemaker and it will be stimulating the brain of the Parkinson patient. So that is nowadays, it's a very important treatment modality for Parkinson disease, not Parkinson plus syndrome, because Parkinson plus syndrome, other areas of brain is also involved. So this is effective in Parkinson disease, most effective in Parkinson disease. So we have discussed about one important neurological disease, that is a Parkinson disease. We have to remember that Parkinson disease is not an isolated entity. Parkinson disease is there, Parkinson plus syndrome is there, secondary Parkinsonism is there. There are a lot of other conditions which can mimic Parkinsonism. So making a diagnosis is mostly clinical, but to rule out other conditions, you can do further investigation and rule out other conditions. And if the patient is having Parkinson disease, their response to methyl dopa carbidopa combination is very good. But even then, after 5-6 years, the effect will come down and patient may not respond to, at one point of time, patient may not respond to the treatment at all. So it is very important to delay the treatment till the patient is not able to, like if the patient is able to do his daily routines normal without any problem. So even if it is slightly slow, we should not start the treatment early. We can wait, because the maximum time period for this type of treatment will be 5 to 6 years. After that, this drug will become ineffective. So we can initially we can advise physiotherapy, preventing fall, diet, all these things modification can be started. Once the patient is not able to do his routine activities, then we can start levodopa carbidopa combination and other supportive medications, bystander training, physiotherapy. All these things are having most important. They are having prime importance, because once these drugs are not acting, the patient will be fully dependent on bystanders or physiotherapy. Thank you.